we are all managing to keep awake. It's just what it was.
Xin lỗi là giáo sư nói về khớp gối chứ không phải là khớp cổ chân à? Là sao họ sẽ đi?
Yes. You ready, Peter? Okay. So, the second last lecture I'm going to give is on ultrasound of the knee. And, you know, we know that ultrasound has opened new horizons in musculoskeletal imaging. It has exquisite soft tissue resolution, and we can image in multiple planes. But it has many advantages over some other imaging modalities in that we can assess for vascularity in real time, and we can perform dynamic examination. And as I've already mentioned, extended field of view has really improved our ability to present ultrasound images to our clinical colleagues. And finally, it's very useful for guiding intervention. In most circumstances, if I'm looking for internal derangement of the knee, I'm going to use MRI. We mustn't forget the role of the plain film as well. X-rays are extremely important. But there are many occasions where ultrasound is an appropriate examination to perform. When I examine the knee, like many of the other joints that I've described, I can use a very systematic approach to looking at the knee. Anteriorly in the knee, we think of the extensor mechanism and the suprapatellar pouch, the kind of the joint. Medially, we can see the collateral ligaments and the menisci. Laterally, we can see the collateral ligaments and again the menisci. And then posteriorly, we can evaluate for Baker's cyst and the neurovascular bundle. Anteriorly, these are all the structures which you should be able to examine using ultrasound. And it's, you know, the anatomy, most of you will be familiar with most of it. Again, I'm using an extended field of view image over here. You can see here's the patellar tendon, the patella, and then the, sorry, I don't remember, that was the quadriceps tendon, the patella, and then the patellar tendon. And you can see there's posterior acoustic shadowing where the patella is. There's the distal femur, and here's the proximal tibia. Sitting deep to the quadriceps tendon is a small fat pad, and beneath that fat pad is where you'll see the suprapatellar pouch, which is normally a thin black structure which is collapsed down unless there is fluid in it. And of course, adjacent to the femur, you have the prefemoral fat pad. And so remember, when you're looking at X-rays, when you see an effusion, you'll see it in this region here, lying anterior to the prefemoral fat pad. So here's an example of a patient with synovitis of the knee. There's the extensor mechanism. You can see it's a child because the patella has not yet ossified. And over here is the suprapatellar pouch, which is distended, and when I put Doppler in, there is some increased vascularity. And this child had synovitis because of a knee joint infection. The quadriceps tendon can be examined in very close detail. We know that there are three main layers to the quadriceps. The most superficial layer is made up by the rectus femoris tendon. The middle layer is made up by vastus medialis and vastus lateralis. And the deep layer is made up by the vastus intermedius tendon. And when we look on a T1 weighted image on MRI, we can appreciate these different layers because there may be a thin layer of fat interspersed between it. But we can also see that when we look at the fibrillar structure on ultrasound, that we can make out the different layers of the quadriceps tendon. With quadriceps tendon ruptures, typically it's a middle-aged patient, and it occurs just above the insertion onto the patella. And what you may see is fluid extending into the pre-patellar region, and there may be a small avulsion injury, like you can see in this case here with a small fragment. And sometimes these patients will present with a mass in the thigh, and so you may have an elderly patient who has had a disruption of their quadriceps but doesn't know that they have done, and they will present with a pseudotumor because the quadriceps muscle has retracted into the thigh, and so they may present with a mass. This is a typical MRI appearance here. You can see fluid in the gap with retraction of the tendon. And you can see how the tendon has come immediately off the bone here, just as it inserts. This is an example that I saw an ultrasound and I decided to do an MRI scan because it looked as if the superficial layer of the quadriceps was injured, and indeed on the MRI scan we can see that the deep layers of the quadriceps are intact, but only the superficial layer is disrupted. And that layer is intact. This is another example where there's a full thickness tear, again an extended field of view image showing the degree of retraction. And again, it may be useful for your surgeons if they're contemplating performing surgery to draw some marks on the patient to show them where the degree of retraction is. You can also get a bursa that occurs at the front of the knee, what we call pre-patellar bursitis. And there are two forms of pre-patellar bursitis. One is clergyman's knee. So that's the priest who is praying on his knees, and that is lower down on the knee, so it's anterior to the tibial tuberosity. Or you can have what we call housemaid's knee, where it's a housemaid who is on all fours, leaning over, and so that occurs higher in the knee joint. So I would describe this one as a housemaid's knee. And you can see that there is internal echoes within the area of bursitis, so it's a thickened bursa rather than one that is distended with fluid. So usually there is no fluid to aspirate. And there may be that there's penetrating injury or blunt trauma. It can be associated with inflammatory conditions such as rheumatoid arthritis. Another example here of pre-patellar bursitis. You can see clinically the patient has a very swollen knee, which is red, and you can see increased vascularity on Doppler. Sometimes there will be fluid distension of the bursa, in which case it's easy to insert a needle and aspirate some fluid. On the medial aspect of the knee, we have the medial collateral ligament, the medial meniscus, the pes anserine tendons, and the medial retinaculum. The medial collateral ligament is commonly injured in the knee as part of a sporting injury. And on MRI, you have a grading system which is shown here. So grade 1 is a sprain where there may be some fluid seen outside the ligament. Grade 2 is a partial tear, and a grade 3 is a full thickness disruption. And so again, I've just drawn in the femur and the proximal tibia here. You can see proximally there's thickening of the medial collateral ligament, and we have a partial tear in this case. Again, this is an MRI comparison, same patient, and the ultrasound shows that there's loss of the normal fibular structure more proximally, with some surrounding soft tissue swelling. The reason that ultrasound isn't ideal for looking at structures in the knee is that we're not able to evaluate the menisci, and we also can't see what's happening in the bone. And so the MRI gives us a lot more information than the ultrasound does in this situation. And this is one where there's a complete disruption of the medial collateral ligament, and you can see that rather than see the normal kind of fibrillar structure of the medial collateral ligament, there is disorganized hypoechoic tissue with marked swelling and a gap. In the chronic medial collateral ligament injury, you might see some calcification or mineralization of the medial collateral ligament, what we know as pedigree sciatic lesion. This is easier to see on ultrasound and X-ray than it is on MRI. For the people who remember their anatomy, the pes anserine is the goose foot. So it's anteriorly you have semimembranosus, gracilis, and sartorius, and that's described as the goose foot because you've got the three tendons that come together, and you can have inflammation in the bursa as the pes anserine courses over the anterior aspect of the tibia, and so you can see here the thickening in the pes anserine. So what about the use of ultrasound for looking at meniscal tears? Well, there's no doubt that in some patients we can detect meniscal tears and we can be very certain that there is a meniscal tear there, but the sensitivity of ultrasound is not good in most studies. And there's one study which showed very good sensitivity, but a rather poor specificity. So let's see what a meniscal tear looks like. Well, often the meniscus is a hyperechoic structure. You can see here, there's the distal femur and tibia. And what we'll see is a tear extending to the surface, such as that. The trouble is, the central portion of the meniscus is usually poorly evaluated on ultrasound, and a lot of tears may occur in that region. So if you do see a tear that extends to the periphery, you can make a diagnosis of a tear, but usually I would then say that the patient should have an MRI scan to confirm the presence of a tear. The one time that you can be 100% certain of a meniscal tear is if you see a parameniscal cyst. And you can see here in this patient, there's a tear there, but extending out more posteriorly is a cystic structure. So in the same way that when we see a parameniscal cyst on MRI, we can be certain there's a tear, it's the same on ultrasound. This is a patient who has a lateral meniscal tear, and as you look more posteriorly, you can see again parameniscal cyst, and this is the MRI of this same patient with the cyst extending into Hocker's fat. What about patellar dislocation? This is often a diagnosis that is missed by the clinician, and also the patient is also not aware of the dislocation. And you see that the injury occurs in three main places: the lateral femoral condyle, the medial patellar facet, and then you also have a torn medial retinaculum. And we know the classic MRI features of this. So there's your injured medial femoral condyle, bone edema there. There's your microfracture of the patella. And on the axial images, you can see it's a kissing injury between these two areas with an injury of the medial retinaculum. And sometimes on ultrasound, we can make out some of those features. Of course, we don't see the bone bruising, but you can see if the retinaculum is torn or avulsed. And so over here, this is a patient who has a small avulsion of the medial aspect of the patella, and there's the MRI equivalent on this patient. But again, if I see this, I'm not going to confidently diagnose a lateral patellar dislocation. I would say that the patient needs an MRI scan. Looking on the lateral aspect of the knee now, we've already seen examples of meniscal tears with a parameniscal cyst. there may be associated synovitis in patients who have this. Ultrasound is very good for diagnosing iliotibial tract syndrome, where you have ITB friction, where the iliotibial tract, the lateral aspect of the knee, rubs against the lateral femoral condyle over here, and there's inflammation and this soft tissue thickening around the iliotibial tract, and this is the MRI equivalent of this patient. One of the things you can do if you're not certain if you're seeing an abnormality is compare both sides. You can see the normal side on the left and the abnormal side on the right side. Looking at the posterior aspect of the knee, the important structure to be able to identify is popliteal cyst or Baker's cyst. And we know that a Baker's cyst always has a very specific origin between the semi-membranosus and the medial head of gastrocnemius. And when we look to see the causes of a Baker's cyst, often there's an inflammatory cause, but often it's just related to osteoarthritis and to meniscal tears. And it's like a valve mechanism that allows the fluid from the joint to be pumped out posteriorly between this pocket of synovium. And of course, the famous ultrasound appearance of a Baker's cyst is the speech bubble sign. So you can see here, this sign over there where it looks like a speech bubble is exactly the same as what we see over here. And the two structures that we're looking at are the medial head of gastrocnemius and the semimembranosus, through which there is a communication with the joint. Again, another example here with the appearance of a speech bubble sign. So just to conclude, the anatomy and pathology are closely linked when we are examining the knee. Consider the four compartments. As I said, as with many other musculoskeletal examinations, it's often a very directed question that is asked. So in other words, your clinician may be asking you, is there a problem with the quadriceps? Is there a problem with the patellar tendon? Is there a meniscal cyst? And so even though the joint may seem very vast and with complex anatomy, often it's a very specific question that's being asked. Use extended field of view, and remember, think of MRI and ultrasound as complementary. Thank you for your attention. This is my hometown, Oxford.
We thank you very much, Professor J.T. One time more. Now, please you take a break and Company can introduce the machine now. Yes? Thank you very much. Sau đây thì chúng ta là nghe công ty Canon sẽ giới thiệu về máy.
Tiếp tục làm thôi.